Kiran, Anil Kumar Cholangi, Arvind Verma, Ajit Changale, Rajesh Goyal, Ashok Sharma, Sunil Kodra, Avinash Tulani. I think one or two are, so we can start with the first talk right away.
So, good morning, ladies and gentlemen. We have the first talk by Dr. Jignesh Thakkar, a prospective study of functional outcome following open reduction and internal fixation in type 3 supracondylar intercondylar femur fracture. Yes, Dr. Jignesh.
Good morning, everyone. Good morning to respected chairperson, my colleague and my seniors. Today my talk is on prospective study on functional outcome following ORIF in type 3 supracondylar intercondylar femur fracture. Distal femoral fracture constitute a challenge to the orthopedic surgeon because of difficulty encountered due to comminution, displacement of the fragment, fracture in multiple plans and involvement of articular surface. There are various methods available with which this fracture can be treated, like retrograde nailing, blade plate, dynamic condylar screw, condylar buttress plate and locking compression plate. We are presenting the result of 40 distal femoral fracture treated by condylar buttress plate in 15 cases and locking compression plates in 25 cases. Coming to materials and methods, our study period is June 2010 to December 2012. This is a prospective study and we follow the routine trauma protocol. When patient came to our hospital, we got the history and resuscitated and X-ray, and for intercondylar and comminuted fracture we took a CT scan. And inclusion criteria is only adult with type C fracture, and exclusion criteria is pathological fracture, pediatric fracture and periprosthetic fracture. We follow up regularly. The patient follow up once in a month for first 3 months, then every month, every 3 months for first 6 months, and then 6 months thereafter. And we follow the needs rating system, which includes the pain, range of movement, function, shortening and angular deformity. We follow the AO classification. Coming to the procedure, patient is on supine position with radiolution table under sandbag under ipsilateral hip, and first through lateral approach we open the fracture site and we reduce the medial and lateral condyle with K wire and fixed with 6.5 mm cancellous screw. Then any articular surface that we reduce with 3.5 to 4 mm cancellous screw, and if any Hoffa's fragment is present, we fixed with 6.5 mm cancellous screw. And then supracondylar element is fixed with appropriate size locking compression plate, and stability is checked, and all procedure maintained under C-arm control. And after found to be stable, we close the wound under with drain in C2. We follow the routine physio protocol. We given knee brace to the patient, and 12th day we remove the suture, and gentle passive range of movement started after 2 weeks, and the gradual weight bearing started after seeing callus on X-ray. Coming to the results, in our patient AO type C1 is 11 cases, C2 is 10 cases and C3 is 19 cases. Coming to the age distribution, the youngest age patient was 22 years and the oldest was 69 years. Coming to gender distribution, most of the patients are males, that is 70%, and females are 30%. And most common side of injury is right side, that is 60%, and left side is 40%. And the distribution of fracture, open fracture is 6 and 34 is closed fracture. From them, 2 treated open fracture treated with locking compression plate and 4 with buttress plate, and from closed fracture 23 treated with locking compression plate and 11 with buttress plate. Associated injuries: head injury in 6 patients, faciommaxillary injury in 2 patients, abdominal injury in 1 patient, chest injury in 2 patients. Other fractures in 12 patients and ligament injury in 1 and shoulder dislocation in 1. The complication associated with locking compression plate and condylar buttress plate. Pain is found in 10 in locking compression plate and 12 patients in condylar buttress plate, and fixed flexion deformity found 6 in condylar buttress plate and 4 in locking compression plate, and functional impairment is found 11 in buttress plate and 6 in locking compression plate, and varus deformity found 8 in buttress plate and 2 in locking compression plate, and shortening of limb occurs in 10 in buttress plate and 8 in locking compression plate. So complication is less in locking compression plate. Then we follow the knee rate score chart. We found excellent result in 40% of cases treated with LCP, and good result in 44%, fair in 8%, and failure in 8%. In condylar buttress plate, 47% good result, 13 is excellent, 20% failure, and 20% fair. Discussion. LCP provides biological fixation, more flexible fixation, indirect reduction, minimal implant to bone interface, and fewer screw and longer plates, and screw fixation stable by lock threaded bolt. In studies by Sendelmeyer et al., 54% treated LCP saw 78% good result. In Higgins found LCP is a stronger construct, and Krager found that is a 71% good result in LCP, and Siliski follow the type C, and 77% has good result in treated by LCP. We follow the knee rating system for functional outcome. Average time for union is 11 weeks. 5 cases gone for delayed union. Varus collapse occur LCP with 2 cases in buttress plate in 8 cases. Range of movement in LCP is 70 degree to 130 degree. Buttress plate 50 to 110 degree. LCP is on 80% excellent to good result. Buttress plate 60% excellent to good result. This is our first case treated with LCP type 3C. You see the range of movement is 110 degree and no shortening. Conclusion. Treatment of type 3C fracture is a technical demanding procedure which experience the skill of an operating surgeon. The availability of locking compression plate helps surgeon to achieve constantly good results with better range of movement and function of the knee. So still our study is very small size, still needs to be more study on this LCP. If we follow the principle of LCP, this will give good result. If we lose the principle, this is called costly failure. Thank you.
Any questions, quick questions? Doctor, you said you approached it laterally and you had 19 C type fractures.
Yes, sir.
And how often can you reduce the medial fractures through a lateral if it is type C and grossly comminuted?
Mostly we'll retract with Homan's retractor and elevate the medial side. Most common is a lateral condyle fracture only. If any medial condyle, we'll retract that part, we'll approach the anterolateral that time.
Yeah, if you have a very bad fracture of the C type, then probably it may be better to use the anterior approach, like the total knee replacement approach, and then it will be much easier to reduce both sides. Articular surface. Okay.
I think Tarpo approach has been described very good for this. Otherwise, you may do one thing with the use shank screw or a thick K-wire and use it like a joystick. Sometimes it helps. Okay, thank you.
Thank you, sir.
Can I call upon the next speaker, Kiran Unashikati?
Should we tell them it's 5 minutes?
It is no program after this, so if it is late by 10.
No, the program is in Hall 8 probably. Yeah, here, yeah. Yes, please.
Good morning, teachers and my dear colleagues. I am going to present functional evaluation of Schatzgert type 5-6 tibial condylar fractures treated with hybrid fixator. Bicondylar fractures of tibia are classified into Schatzgert type 5 and 6. These continue to pose challenge to orthopedic surgeons while its management is considered. It's characterized by its injury to the soft tissue envelope, significant articular depression, severe fracture comminution and displacement. The most effective operative treatment method includes open reduction reflexation with minimally invasive osteosynthesis and Ilizaro and hybrid fixator. The traditional known complications of ORIF are soft tissue necrosis, infection, non-union, and need for resurgeries. In the early 1990s, the Ilizaro and hybrid fixator started becoming popular in treating these injuries. And the hybrid fixator combine the part of ring and half pin external fixator. The advantages of hybrid fixator are it provides adequate fracture reduction and stability and permit early knee mobilization and respects soft tissue envelope, but it's costly. So this is an indigenously designed hybrid fixator. It consists of 5/8 Ilizaro ring, standard external fixator rod, Ilizaro thread rods, Steinman pin, Ilizaro K wires and olive wires, and Shams pin. So the present study consists of 42 fractures in 41 patients with a minimum follow-up of 2 years and average follow-up duration of 53 months. And the period of study is between 2004 to 11. And average age group is 44 years. And the study constitutes 11 cases of type 5 fractures and 31 cases of type 6. And 3 cases were associated with open injuries, and 10 cases had associated injuries like other musculoskeletal fractures or abdominal or thoracic injuries. The initial stabilization was done according to ATLS protocol, and standard radiographs were taken and CT scan was used to analyze the fragments. Closed fractures were treated with traction, splinting and knee spanning external fixator, and open fractures were treated on immediate basis. So patient was put on traction, fracture table, and traction was given, and indirect reduction was achieved by ligamentaxis, and articular depression were elevated, and intercondylar reduction was achieved and fixed with screws. And 3 tension transfixion wires were connected to the 5/8 Ilizaro ring, and olive wires were sometimes used for reduction, and rod portion was connected to distal fragment with 3 mm Shams pin. This is a fixator in situ. In the postoperative protocol, splint was given for 3 weeks, and then knee mobilization was begun with a fixator in situ, and non-weight bearing was continued till significant radiological union was seen. The patient was followed up at a 4 weeks interval till complete union and assessed clinically and radiologically. After satisfactory radiological union, hybrid frame was removed and partial weight bearing was begun, and knee mobilization and muscle strengthening exercises were started. So the patients were assessed clinically and functionally by IOA knee score, and radiologically by Hankonins and Gervin's rating. Coming to the results, there were 64 patients had excellent score, and 29% had a good score, total constituting 93% of good to excellent. And poor functional results had associated multiple injuries in the same limb. In our series, 24% had associated injuries, and the score is comparatively less in the patients with associated injuries. The score between type 5 and 6 are of almost negligible, and in the radiological outcome is measured by Hankonins and Gervin's rating, and 14% had a excellent result, and 50% had good outcome, total constituting 64% of good to excellent. In the early complications, 1 patient had screw infections and 8 patients had pincet infection. In the late complications, 3 patients had a knee range of movements less than 90 degree, and 1 patient had 15 degree malunion, valgus malunion, and 1 patient had 10 degree valgus malunion, varus malunion. And 26% have post-traumatic osteoarthritic changes radiologically, but functionally they are doing well. So to conclude, the treatment of hybrid external fixator is a good option for tibial bicondylar fractures, where severe combination and soft tissue factors make open reduction and internal fixation unsuitable. This is a case of 49-year-old man presented with RTA, had type 6 fracture, treated with a hybrid external fixator in hospital, and this is a follow-up after 2 years, and with a knee range of movements of 135 degree flexion and full extension. And another case of 44-year-old man with a significant soft tissue injury, sustained type 6 fracture, treated with hybrid external fixator, and this is the radiological picture. Another case of 59-year-old man presented with RTA, had type 3B open gustalo fracture with associated patella and lateral femoral condyle fracture, treated with fixator, and this is the X-ray following implant removal. And the long-term follow-up study done by various authors have the comparable results with our study. Thank you, sir.
Any questions to the presenter?
Is how close your pins into the near the joint?
Sir, minimum 20 millimeter from the lateral cortex means.
And the other thing, did you ever use a spanning across the knee joint?
Yeah, means when the soft tissue was not good enough, and in case of open fractures, we used knee spanning external fixator until the soft tissue healed, and later it was converted, usually within 3 weeks, converted to the hybrid.
One more thing is, do you really use a traction table to give a traction for the bad injuries? It's a real bit of concern in the sense, such a severe soft tissue injury, if you put a traction, there are two concerns. One is intra-articular ligamentous injury, another one is soft tissue. I mean, these two are major concerns. Soft tissue can give rise to compartment. If you got an intra-articular ligamentous injury, that can give rise to bad results. I mean, I don't know. I really don't know the answer for that. But I never seen anybody using a traction for that. Traction, put the patient on a traction table and apply fixator. I mean, it's not a good idea. I don't know.
We have not encountered such problems.
I don't know.
Thank you.
Any more question? The last one.
Hello, doctor. I had two questions. Like, one is how you are going to achieve when there's severe articular combination, how you are going to achieve the articular congruity with the hybrid fixator itself. One. The second one, what were the actual indication for you to go for a hybrid external fixator? Because most of the type 5 or type 6, when there's articular combination, we usually go for plating where we need to achieve good articular congruity. But what I feel is with an external fixator, hybrid external fixator, you may not be able to achieve proper articular congruity when the patient is so young. So how you are going to tackle with those things?
With the traction, the satisfactory reduction, if it is not achieved, a mini open reduction is done. With the reduction portals, we achieve the reduction and external fixator is applied.
But what I feel is you may not be able to hold with an external fixator the articular congruity. How you need some screws to hold it at least.
Yeah, means screws are put, means 6.5 mm screws are put to hold the articular surface, and over that hybrid fixator is applied.
He had shown the X-rays where he has put screws. Yeah, the whole principle is that you have to get the joint line in congruent, and then you can use whether a hybrid fixator or Elizaro or plate or whatever you want.
Whatever.
So the principle is that you have to get the reduction proper in the articular surface, and once that is achieved, then you can use whatever. So the hybrid fixator is actually, once you get the reduction perfect, and instead of a plate, you can use the hybrid fixator.
Okay.
That is the only thing. So you have to get the alignment correct, you have to get the congruency of the articular surface correct. That is the true principles of doing this intra-articular fractures.
One more question is, except for severe soft tissue contusion, soft tissue injuries and compound, what other indications were there to use an external fixator itself, rather than we can use a plate itself?
Cost factor. Yeah. It's a huge cost factor.
Plate.
If you are going to use, like the previous presenter, if you are going to use a LCP plate for this, this is going to be at least about 16 to 20,000 rupees for the plate and screws alone. So that is probably one of the...
Yeah, cost factor is also one of the these things.
Fine.
Okay.
Thank you.
Yeah.
Thank you very much.
Thank you.
May I call upon the next speaker, please? Anil Kumar Cholangi. Posterior buttress plating and useful tool for posterior bicondylar fracture of tibia.
Second, Arvind, second, Anil Kumar. Stage Anil Kumar. Good morning, sir. Good morning to all. I am Dr. Anil Kumar, PG in Orthopedics in Rangaraya Medical College. My topic is posteromedial buttress plate is an usual tool for bicondylar fractures of the tibia. Bicondylar fractures of the tibia constitute approximately 1% of all fractures. A posteromedial fragment accounts for 1/3 of the bicondylar plateau fractures. It's most commonly seen in males due to high energy trauma involving road traffic accidents or fall from height. And there are numerous classifications. There are Schwarzkopf classification, Holland-Moore classification, and AO classification. But none of the classification is reliable. The standard open reduction and internal fixation with lateral and medial plating and recent fixed angle lateral locking plate are not addressing the posteromedial fragment. This leads to posterior subluxation of femur in stance and unstable femoral tubular articulation, a stiff and arthritic knee. Posteromedial fragment was first mentioned in 1967 by Hall. The posteromedial fragment exhibits vertical fracture patterns suggestive of shear instability and vertical displacement. Failure to address this fragment may allow medial femoral condyle to rotate and subluxate posteriorly, causing instability, pain, and progressive joint degeneration. So we have conducted a study to evaluate the clinical and radiological outcome of bicondylar tibial plateau fractures with posterior displacement treated with posterior buttress plating. From June 2012 to 2013, we have conducted a prospective study by identifying 10 patients between 20 to 60 years with bicondylar fracture tibia with posterior displacement and investigated by plain X-rays and CT scan, managed by posterior and lateral buttress plating and screws through posterior or posteromedial approach and anterolateral approach. The inclusion criteria being bicondylar fractures of the tibia, medial tibial condyle fractures, Moore's type 2 fracture, and 20 to 60 years age group and closure fractures. Open fractures, polytrauma patients, pediatric fractures, and pathological fractures are excluded from the study. The surgical procedure is being under supine position, posteromedial or posterior inverted L-shaped incision is given, and it gives the direct visualization of the posterior articular surface. And we have applied the posterior buttress plate using anticlate technique, and lateral screws are applied percutaneously or buttress plate through the anterolateral approach. This is the standard posterior inverted L-shaped incision. Post-op protocol is being a functional position brace was used for 4 to 6 weeks. Quads exercises were advised and weight bearing was delayed for 18 weeks. All patients were followed up for 6 to 18 months and mean follow-up duration was 12 months. 7 out of 10 fractures united on the average of 24 weeks. Average range of flexion of the affected knee is 45 to 120 degrees at 12th month follow-up after operation. Stiffness of knee joint in 3 cases and 2 cases have incisional wound infection. No patient showed knee instability, implant failure, and no cases have significant shortening. The functional outcome was analyzed using Oxford knee score and Lysholm score. The radiological outcome by plain radiographs for trabecular continuity. The results were excellent in 4 cases, satisfactory in 3 cases, and poor in 3 cases. This is a 50-year male patient met with road traffic accident and sustained a type 5 fracture, investigated by X-rays and CT scan and operated on 10th day after injury. This is the pre-op X-ray and this is immediate post-op X-ray. This is 12th month post-op X-ray, and he had got a good range of flexion and extension. 40-year male patient met with road traffic accident and sustained Moore type 2 fracture and posted for surgery on 12th post-operative, and we have applied exclusive posterior plating, and this is the range of movements here. This good range of flexion and extension has attained after 12th month follow-up. 43-year male patient met with road traffic accident, sustained Moore type 2 fracture and operated by posterior and posteromedial and lateral plating, and he got a good range of flexion movement. This is the 4th case. Bicondylar fractures of the tibia with posterior displacement. We have applied posterior plate and lateral screws, and this is the recent case we have done and waiting for the results and discussion. Treatment of bicondylar tibial fractures with posterior displacement is challenging. Posteromedial fragment is unlikely to be engaged by laterally based locking implants, and posterior displacement is better addressed by posteromedial buttress plating. The advantages are being diminishing the risks of articular incongruency, reduces the malalignment of mechanical load axis, and decreases the post-traumatic degenerative joint disease. It allows anatomic joint reduction, minimal iatrogenic soft tissue damage, and provides adequate fixation of the fracture, permits early functional range of motion, and less complications and better clinical radiological outcome on long-term follow-up. The limitations of my study are being a non-randomized study. It's a small group and short duration of follow-up, and awaiting for the long-term outcome. To conclude, posteromedial buttress plate fixation is the best treatment option for bicondylar fractures of tibia with posterior displacement. It is more biomechanically stable for fracture pattern, and posterior displacement is better reduced. It avoids extensive soft tissue dissection and allows early painless range of motion. Thank you.
Questions are invited. Any question, please?
I think there is a little confusion between the posteromedial fragment and the shear posterior fragments that you are talking. Are you talking about the posterior shear fractures of Bhattacharya?
Actually,
or are you talking about the bicondylar fractures with posteromedial fragment?
Actually, we have included the two cases, both the type of cases.
I don't think you should be mixing up these two, because many of these fractures or bicondylar fractures would be having a posteromedial fragment,
Yes, sir.
which is a large fragment, and it is displaced posteriorly, which has to be fixed first.
If it is more than
But
25%
the
of
other type of fractures, which I think your heading is posterior buttressing for posterior bicondylar fractures. Posterior bicondylar shear fractures, there's a different entity altogether.
Yes, sir.
Yeah, so you have on the
We have
medial
changed.
side and as well as lateral side, and you have a different approach for the medial and the lateral side.
Yes, sir.
So I don't think you should be mixing up these things. I think you have mixed it up.
Yes, sir. Actually, we have changed that, sir, posterior bicondylar fracture with posterior displacement. Bicondylar fracture with posterior displacement, sir. We have
Yeah.
changed the topic.
Okay.
One question. Which plate you use for fixation and posteromedial fragment?
We have used locking plates, sir.
Locking pre-contour plate?
Actually, we have used a distal tibial locking plate, and we have contoured in.
You contour the
Insert.
locking plate to the
Yeah.
posteromedial fragment. Is it difficult, interrupt, to contour a locking plate? It is a heavy duty plate.
Yes, sir.
And
It's difficult.
Isn't it bulky in the posterior compartment?
No, sir. It's not that particular.
And use 5 mm locking screws?
We have used 4.5.
You can contour a 3.5 mm locking plate and put it posteriorly. We can also use the small fragment for the ones which you use for wrist. Yeah, but that's why I asked you the first question is because he is confusing between those two fragments. But if it is a small, usually the shear fractures on the posterior side, on the medial and the lateral side, are rather small fragments. So you can use this plate.
Small plate fits there better, but
Yeah.
problem is we don't have generally long screws with that small plates to hold that whole tibia.
Yeah, but if you use the locking screws, you can use unicortical screws for that also. Because it's difficult to put in 3.5 right into the anterior cortex. So if you can use locking screws, and then you can do it with unicortical screws.
In fact, these are the fractures where the Schatzker classification doesn't hold true, and
Yeah.
this is the limitation. But now we are, the studies are coming up for importance of this fracture, and the newer classifications are coming up, because this is very important fracture, the posterior and the posteromedial in intercondylar upper tibia. So, thank you. Next speaker, Dr. Arvind Verma.
Comparative study of treatment of fracture of the distal end of femur, supracondylar retrograde interlocking nail versus distal femoral locking plate.
Yeah. Good morning, everybody. As per the topic, the distal femoral fractures are difficult to treat. They pose a therapeutic challenge, and in varying degree of permanent disability they result. They tend to occur in elderly as well as multiply injured patients. In older patients, it is complicated by the previous joint arthropathy and arthroplasties. Earlier, non-operative treatments, they were preferred, but with the development of improved internal fixation devices by the AO group, the treatment recommendations, they have begun to change. This is a relevant anatomy. The mechanism of injury for this fracture is due to axial loading, varus valgus and rotational forces strain, and these are the various deforming forces to the fracture. Epidemiology, the high energy fractures, they occur in the male between 15 to 50 years of age, and low energy fractures usually occur in the osteoporotic bones. Because of the proximity of these fractures to the knee joint, the regaining of full knee motion function is difficult. The treatment options are usually surgical fixation has become a preferred mode of management. The aim of surgery is anatomical reduction of the articular surfaces, restoration of alignment rotation, as well as early mobilization. The distal femoral locking plate is a single beam construct which provides strength of fixation which is equal to the sum of all the screw bone interfaces. And it is a pull-out resistant, and the biomechanical function is based on splinting rather than compression. It provides flexible stabilization with awareness of stress shielding and helps in induction of callus. It is well contoured and have a multiple locking screw options distally. The insertion jigs helps in percutaneous insertion of screws. It is less technically demanding in comparison to the blade plate. It is applied by Beppo's technique, allows the prompt healing, reduced bone resorption is there, and the outcome in it correlates with the fracture severity, anatomical reduction, etiology, bone quality, length of time elapsed, and the position and fixation of the implant. It is based on the principle of bridging, and it works best in the comminuted, intra-articular as well as osteoporotic bones. The soft tissue attachment of the fragment is preserved, and the fragments are relatively well aligned. In the case of retrograde nail, it protects the soft tissue envelope. It is minimally invasive approach can be used. Close reduction techniques can be used. And reaming nails, this allowed the use of large diameter implants. The biomechanical function is based on load sharing rather than load sparing. It provides flexible stabilization with avoidance of stress shielding and helps in induction of callus. It works best in the supracanal, extra-articular as well as osteoporotic bones and fractures. We have used a static locked retrograde intramedullary nail for most of the AO type A fracture and many of the type C1 and C2 fracture. Type C1 and C2 fractures with the non-displaced intercondylar splits, they can be converted into type A pattern with the percutaneous screw fixation. However, it carries a great risk of a large entry hole and damage to the articular cartilage. The review of the literature, many of the authors, they have studied the function of these plates and retrograde nailing, and they have found good results. In our material methods, we have conducted the study in 30 cases. 15 were treated with plating and rest 15 were treated with the supracanal nail. The clinical assessment and comparison was done at least 6 months post-operatively, and knee score was used. Inclusion criteria, the fracture of the distal femur, AO33A and 33C was type O included. Patient more than 15 years of age, non-infected, non-contaminated, open fracture up to the grade 3A. And exclusion criteria, open fracture contaminated or 3B and 3C. Fracture in the pediatric age group less than 15 years of age not included. In our observation, in the plating and nailing group, we have found that the age usually was, as told by the earlier speakers, mostly in the elderly patients and around more on the right side and more on by the roadside accidents. The observation is also that the simple fractures are more in the plating group, about 80% and 20% were compound, and similarly 78% and 22% compound fracture in the nailing group. In the plating group, about 77 fractures were classified as C-type fracture and the rest 23% were type A fracture. In about 46% of the fracture with classified type C fracture and the rest 54 were classified in the type A fracture in nailing group. In the plating group, the bone grafting was done in 48% of cases, while in plating it was done in 24% cases. And around in the plating, 78% of the cases also were fixed with distal fragment with interfragmentary screws, while in 18% in nailing group. In the plating group, we have used the central TKR approach with the Schwarzbuckler or anterior-medial approach. And these are a few intraoperative X-ray converting the C1 type to A. These are preoperative and postoperative X-rays. This is a post-op range of motion. These are the results. And we were able to reach the range of motion for more than 90 degrees in about 13 cases. And complication was like superficial infection, knee stiffness, non-union as well as man-union. In the supraclavicular nail, these are the operative X-rays. This is a patient showing physiotherapy. In again the nailing group, the A grade type of the fracture showed better result than the C type fracture in the nailing group. Again, this in here also we were able to arrange a good range of motion with massive physiotherapy. In the complication, again, the superficial infection, knee sepsis, knee stiffness, patellofemoral problem, and non-union were there. In the comparative result, the difference between nailing and plating, we have found on the basis of osseous sealing, rate of non-union, and post-operative complication. The results in the A group in the plating and nailing are as shown, and they are showing good to, in the A group, we have shown that the supracanal nailing is showing a good result, as well as plating is also showing good result, but because the percentage was such that it seems that the supracanal in A group is better than in the plating. In the C group, again the we are seeing here that the good to excellent results are seen in the plating than in supracanal nailing. In the conclusion, LCP is an implant of choice in AO type C, a comminuted fracture of distal end of the femur, even with the little bone stock and elderly patients with osteoporotic bone. We have recommended a few tips for good plating outcome as per our observation. We prefer the Mipos technique, don't disturb the biology of the fragments, don't avoid the angulation and malalignment, the fragmentary screw, interfragmentary screw, not not to interfere with the plate placement. The contour of the plate should match with that of the bone. Early physiotherapy should be instituted. In the retrograde nailing, though associated with the knee joint problem, because it can be a good option with type A fracture. It provides a more biological friction. We also recommended a few tips for the good supraclavicular nailing outcome as per our observation. We must bury the nail deep and avoid any chance for fracture or the joint infection. We try the closed nailing, but don't hesitate to open it if the fracture reduction is not possible. Don't hesitate to change the plan to plating if required. Avoid angulation, malalignment and shortening. Always assist early physiotherapy with weekly supervision. Otherwise, the patient may develop stiffness even after if you have seen that the range of movement has developed. Lastly, in conclusion, A or type C fractures are generally best treated with plating technique, whereas nailing probably is the preferred for type A fracture and distal femoral fractures with extensive shaft tissue excision. I thank you very much.
Questions,
Thank you,
please.
What about the incidence of type A fractures treated with supracondylar nailing because it is unviolated knee? Stiffness and patellofemoral problems.
All depends upon the burial of the nail inside the articular surface. If you are burying it and followed by good physiotherapy, you will have a better result.
In case
if
of
you see that type C fracture you want to treat and have good result, in the type C3, you definitely are going to have a bad result. As per our observation.
You said in complicated cases you use plating. Do you do grafting primarily or later on?
We see that if there is large combination and in the C-arm control or in the intraoperative we find that there is a void and there is a split, a lot of combination is there, we prefer to put the primary bone grafting. We have even used a tubular method to deliver the bone graft into the fracture site by using the large sleeve that we use for putting the, to just take the pulp from the distal and proximal end of the tibia and put it in the sleeve and push it with a screwdriver into the fracture fragments without opening.
In those cases you do physiotherapy later. You go for, in those cases where you do grafting, physiotherapy, post-op physiotherapy start after how many days?
Just after, assisted physiotherapy can be started just after 24 to 72 hours.
Oh, thank you.
Doctor, you have compared the supracondylar nail with the plate. You have not taken similar cases, but because you have 78% of them were treated with interfragmentary screws in your plating technique, and only 17% in the nailing technique, which means the combination was far more in the plating technique. So it's difficult to compare the nail with the plate in different scenarios. So that the plate has its own function, the nail has its own function, but I think when you compare, it has to be in a similar type of fractures.
Actually, sir, we we treated the first 15 cases with the supracondylar and then with the plating, and we didn't care, we didn't choose it, it is a type, we should do it that way. We just did the 15 cases and then just did the 15 cases and just we tried to follow. It was just by incidence, by chance that those people were there in that group.
Because in the more comminuted fractures, you can't use the nail.
Yeah, you can use but you have to open it definitely. Yeah. You have to open it, do primary grafting, and the results as we go from C1 to C2, C3, the results in supracondylar nailing becomes more bad. So we have actually abandoned.
C3 fractures are difficult to treat with the nail because you will have to use so many interfragmentary screws that you don't have space for the nail after that, or the transfixing screws.
So rather with this experience we have.
Because I am trying to pass a message for people who are listening to you that type C3 fractures and all that should not be attempted with the supracondylar nail.
In my recommendation I have told that if you find that you are planning to do supracondylar nail, but if you find there is a split, don't play with an ego. You just go and change your plan to plating.
Okay. So rather than the comparative study, it should have been the choice of treatment in distal femur. Thank you very much.
Thank you.
Next speaker, please. Ajit Jangale. Effect of posterior tibial slope on functional outcome of bicondylar tibial fractures.
Good morning, everybody. Today I'll be talking about the effect of the posterior tibial slope on the functional outcome in bicondylar tibial fractures. As we all know, tibial plateau fractures are common as well as challenging fractures to treat because they require anatomical and stable fixation, and they require early rehabilitation and restoration of the articular alignment, otherwise it leads to knee stiffness. Now, there are various factors which determine the outcome of this fixation. One is the age of the patient, the type of the fracture, bone quality, severity of the displacement, and obviously the fixation method used. But does the proximal tibial slope have a bearing on the proximal tibial fractures? Now, what is the significance of the proximal tibial slope? It's a bony factor which contributes to the anterior-posterior stability of the knee and the amount of anterior tibial translation. Now, we know that sagittal plane deformity exists in majority of the bicondylar fractures, but we've realized that there have been no studies on the post-operative sagittal alignment in tibial fractures, although there have been various studies of the same in knee arthroplasty. So we hypothesized that the proximal tibial sagittal alignment, that is the PTS, may have an effect on the outcome of bicondylar tibial fractures. We aim to study the effect of the PTS on the outcome of the proximal tibial fractures in terms of knee ROM and functional outcomes. We studied a total of 40 patients in a span of 2 years from 2008 to 2010 and included Schatzker type 5 and type 6 fractures in our study, and we followed them up for 1 year. All fractures were treated internally with plate fixation. We evaluated our data at 3 months, 6 months and 1 year of post-operative, clinically by the knee ROM and deformity, and functionally by the WOMAC scoring. Now, how do you measure the PTS? The PTS is measured by joining the anterior and the posterior ends of the tibial condyle and finding the angle that it makes with the perpendicular to the tibial axis. Now, studies done by Homan and Hudek, they showed that the normal range of the PTS is around 4 to 14 degrees of posterior slope. So we divided our patients into 2 groups, that is the neutral group and the non-neutral group. The neutral patients ranging from 4 to 14 degrees and the non-neutral either less than 4 or more than 14 degrees of slope. Now I'll show you a few cases here. Now this particular patient, if you see the pre-op, the immediate post-op and the 1 year follow-up, this particular patient developed a negative, that is a posterior collapse. Gradually the angle was increasing and ended up in the non-neutral group, that is more than 14 degrees. Another patient is similar posterior collapse. No, but we found that patients with a more than 14 degrees of PTS tended to develop a flexion deformity. Now, this is the one neutral patient. His angle was within the range of 4 to 14. Another patient, and they had no deformities and a very good knee range of motion. This is a patient with anterior collapse that is less than 4 degrees, and these patients tended to have a recurvatum. If you see our results, we had 15 patients out of 40 in type 5 Schatzkers and 25 of type 6. We ended up having around 2 delayed unions, 2 delayed wound healing and 1 infection. And we also had 9 patients with deformity. We found that the knee range of movement in the neutral group was approximately 120 degrees and the non-neutral group was around 106 degrees. There was a statistical significant difference amongst the 2 groups in terms of knee range of movement. But the sub-scores of the WOMAC scoring were not a significant difference amongst the 2 groups. Now, we all know that anatomical alignment is one of the basic requirements for good fracture fixation, especially for lower limb, because the maximum body weight is transmitted through the lower limbs. So, when we considered the normal range of movement to be 4 to 14, we found 31 patients within the neutral group and 9 patients either had a positive or a negative slope. And we found that the posterior tibial slope does affect the knee range of movement significantly, but has no statistically significant difference on patient-dependent scoring in terms of WOMAC score. Another interesting finding we found was there was most patients had a change in their PTS over the span of 1 year, that is either a posterior or an anterior collapse. The limitations of our study: firstly, we had a relatively small sample size of just 40 patients, and we used conventional X-rays instead of CT scans. CT scans would be preferred. And the tibial slope reference value was from studies which were done previously, but not compared to the opposite normal knee. I conclude my talk by saying that we believe that this study can be considered as a pilot study in terms of knee range of movement, the effect of PTS on the knee range of movement in fractures rather than arthroplasty. And we found that it does have a significant outcome in the range of movement, although not on the functional scoring. Another interesting finding, as I said, was the delayed post-operative collapse in the over span of 1 year. Thank you.
Thank you, Doctor.
Questions are invited.
It's an interesting study, but why didn't you measure the opposite side? I mean, it's not very difficult to measure the opposite side.
Yes,
And another thing is that most of these cases you would have done a CT scan. Normally, for intra-articular fractures, you would prefer to do it, you should be having CT scan facility, isn't it?
We do so, but there was a drawback of the cost of the CT scans. But it was a retrospective study actually, so.
Yeah.
it
Oh,
was
a
a
retrospective
drawback.
study.
It was a retrospective.
Okay.
It was a drawback of our study.
Yeah, yeah. So, yeah, it's an interesting study, but I think you should do it prospective and then measure the opposite side, and maybe with the CT scan it will be more accurate.
Yes.
Good talk, Dr. Jangle. When did you start mobilizing the knee post-operatively in these cases?
Most of the patients were mobilized within the first week itself, depending on the stability of the fixation. In case we felt that the fixation was maybe not up to our mark, then maybe after 3 weeks.
Do you feel that also played a factor, or played a role in the ultimate outcome?
Yeah, definitely, yes. That's
Good. Thank you. Thank you, Dr. Ajit Jangle. Next is Dr. Rajesh Goel. Surgical management of displaced fracture patella and innovative method.
तो करना तो नहीं पड़ेगा ना? Respected Chairperson, sir, my seniors, colleagues and friends, good morning to all of you. I am presenting an innovative study of fracture patella fixation. We often encounter such patients who complain of palpable implants and pain at the patella side or the knee joint because of the implants. Is it possible to have fixation of the patella without wires, or we face such situation where there is breakage of the implants? Can we have normal range of movement which is painless? So we included 25 cases of closed fracture patella, which is less than 3 weeks old. Both male and female sex were involved. We know transosseous fixation of the patella, the tensile forces are converted into compressive forces. In our study, we fixed this transosseous fixation of the patella with endo button, in which there is interfragmentary compression as well. Here, this is the armamentarium of our study. There is endo button, which we are using 4 endo buttons. The polypropylene suture material, cannulated drill bit, K wires and suture passing needle. This is the endo button. First hole where suture material is passed in first and fourth, and second one is passed through second and third. This is how we construct the endo button. First of all, this simple is reduction. We first of all reduce the fracture fragments, pass 2 K wires as we do in tension band wiring. Then we pass the cannulated drill bit, and then we make a figure of 8 construct for interfragmentary compression. This is how we do it. Then we tighten the construct, and then we tighten the figure of 8 compression. This is the video. After the construct, we have tried to mobilize on the table, and there is no destruction and no separation of the fracture fragments. The results, as we have shown, all fractures united at the mean interval of 10 weeks, 22 were excellent, 2 were good, and 1 was fair. The complications were, there was loosening of endo button in 1 case and tilting of endo button in 4 cases. None of the patients reported painful or palpable hardware. This is case 1, comminuted fracture patella. We use 4 endo buttons. This is full range of movement. This is case 2, which is showing 4 endo buttons fixed with this patella. This full range of movement. She is able to squat, she is able to sit cross-legged. This is case 3. In conclusion of the study, we can fix the fracture patella with endobutton and polyester suture, which minimizes the incidence of palpable or painful hardware and avoids the need of second operation for hardware removal. This is the take-home message. Thank you very much.
Thank you, Dr. Ashok Sharma.
Any question, please?
Questions?
A very novel idea, Dr. Sharma. I'm Dr. Parag from Pune.
Dr. Rajesh Goyal.
Oh, sorry.
Parag,
So-
I know we were there in Germany.
Yes, I remember that. Excellent idea. So my only question is, the K-wire and TBW principle is that every time you flex, you get compression. So have you seen that this
That is why I have shown this video.
It's
On
excellent.
the table,
No, so-
we were doing up to 90-degree flexion, and there was no distraction on the table in front of our eyes.
So that's an excellent idea, because many a times patients come back, the
We
wires are
often
broken.
encounter such patients, they want the removal of the implants, especially the TBW. They always want the removal of the implants.
Okay, that's good.
What is your post-operative mobilization protocol?
Sir, after 10 days after suture removal, we start the patient to weight bearing and gradual mobilization. Weight bearing is started after suture removal.
But knee bending?
So knee bending is after 2 weeks.
What is the function of the endo button, Dr. Goyal?
So function, there has been, in the world literature, there has been no such study till now. We have done this for the first time. People have used the needles, people have used something else also. But the endo button is fixing the fracture fragments together. On both the sides, there are 2 endo buttons on the upper side and 2 endo buttons on the lower side. So both the 4 endo buttons, they are fixing the fragments with the help of polyester suture. We are making such a construct, such a strong construct. You can see the polyester suture 50. It is so strong that with the help of this strong construct, there is no separation.
Yes.
Is there any difference tying the knot directly or without an endo button?
Yeah, there is a difference. If you tie the knot without endo button, then the suture material may dig into the bone because it's a cancellous bone. So there are chances of loosening of the fragments later on. As soon as you try to mobilize, there is chance of loosening of the fragments. So we have to use such material which can give some strength at the bone side.
But you said you're passing it through different holes. So there must have been some cortical bone between the holes.
No, the endo button is a very small thing, you see, and it juts into the, it juts above the patella as well as in the inferior part of the patella. So it makes a resistance against digging the polyester suture.
I think you can discuss it with him afterwards. One last question, Dr. Gors.
So your indication was just to prevent the irritation of the skin and painful, you started choosing instead of K wires.
Yeah.
And figure of 8 wires.
Yeah.
You choose this technique.
Yeah.
Right. But there are certain things,
Yeah.
In fracture patella, basic thing is give a compressive force
Yeah.
towards the quadriceps tendon and patella tendon.
Yeah.
Fracture union is not permanent.
Yeah.
Even you give a simple plaster.
Yeah.
Within 4 to 6 weeks, the fracture unites.
Yeah.
But why we do the tension band wiring is because the separation, because to prevent the separation of the 2 fragments, keep them there by figure of 8 wiring.
Yeah.
Right there.
Right.
In transverse fracture, we put 2 K wires also.
Yeah.
In other fracture, we fix each fragment.
Yeah.
Then we put a round
round,
wire,
yeah.
then figure of 8 wire and
Yeah.
leave it.
Yeah.
And as far as weight bearing is concerned, we start the patient weight bearing just immediately.
It is possible.
And
possible.
regarding bending of the movements, you can start as the pain according to the pain, not after the stitch removal. When he is walking, at least 30 degree of movement is there.
Yeah.
So once you start walking, very next day he can walk.
No,
and
he
more
can
he
walk.
walks, more he does the flexion, more compression there on the fracture side. So my meaning is, just for a simple thing, And that simple thing was happened because the wires were not twisted well and inserted into the soft tissue.
Sir, my submission
And that's
to
why
you,
there's
yes, sir.
irritation.
Yes, sir. My
Otherwise,
Yeah.
if you twist them well, if you insert them inside the whole bone or part of the bone, they will never ever irritate.
Sir, my submission to you is that in most of the cases in TBW patella, the patient complain of palpable implants, and sometimes the breakage of the implant is there, and they always ask for the removal of the implant. That is the basic thing.
I think we will stop here because it's a never-ending debate. New innovative idea.
Yeah.
Next.
No. Till now, it has been 1.5 years since we are doing it, and none of the cases came to us for the removal of
Thank you,
implants.
Dr. Goel. Now we move on to next.
Thank you very
Dr.
much.
Sunil Gudara.
Thank you very much.
Dr. Sunil Gudara. Dr. Avinash Tolani.
Is he present?
Presenting a role of supracondylar nail in the management of distal femoral fracture under the guidance of Dr. Omshas. Fracture distal and femur has always been a challenge to orthopedic surgeons as the management of these fractures is difficult and controversial. In the recent years, close intermedullary fixation has received increased attention for the treatment of distal femoral fracture. These devices obtain more biological fixation than plates because they are load sharing rather than load sparing implants. Use of these implants is indicated in the management of both distal comminuted fracture, non-articular fractures, and fracture with the interarticular extension. Intermedullary fixation provides better fracture stabilization in both elderly patients with osteoporotic bone and younger patients with extensive comminuted fracture. Nowadays, incidence of high velocity trauma has been increased, especially motorcycle riders met accident and sustained supracondylar fracture with fracture leg bone, floating knee. These type of injuries are best treated with supracondylar nail for fracture supracondylar and interlocking tibia for fracture leg bone through a single small incision. This is a prospective and retrospective study, January 2010 to 2012. Fracture pattern included in our study was a distal femoral fracture, AO type 1, 2, 3 and C12. Number of patients included were 100, 18 female, 82 male, mean age was 46 years, and fracture most common was in right side. Position, we take patient in supine position with knee flexed to 90 degree, achievement of accurate reduction by placing a pillow under the distal end femur by manipulation of extremity. In T or Y comminuted intercondylar fractures, after close reduction of intercondylar fracture fragment, fixation done with screws or Steinman pin placed transversely across the intercondylar fracture in the anterior half of part. The intercondylar fracture fixation was done before supracondylar nail incision to prevent the displacement of these condyle. This is showing image. Intercondylar areas are fixed with Steinman pin to hold the intercondylar area in position, and we pass the reamer below this. And this Steinman pin also help to act as a polar screw to prevent the nail passing anteriorly. Portal of entry. The entry portal was approximately 2 to 5 millimeter anterior to the posterior cruciate ligament. In the fluoroscopy, point of entry should be in the line with the long axis of femoral shaft in both epi and coronal planes. Blumenset line was also used. Make entry at this point with a hole, pass a guide wire through this hole in distal fragment, or this guide wire pass 8 mm cannulated solid reamer. Under IITV, close reduction of fracture fragment done, guide wire passed in the proximal fragment using reamer as a manipulative devices. Incrementally reaming done. Selected supracondylar nail mounted over the jig and passed over the guide wire up to 1 to 2 millimeter under the articular surface. Distal 2 to 3 locking done through the jig. Before proximal locking through the distal jig or free hand, see the fracture, reduce it by compression or manual traction if necessary. Wound closed and compression applied. After operation, knee stabilization is checked. If found unstable, then a cylindrical slab applied for 3 weeks. In some T or Y fracture, if close reduction is not achieved, then open reduction with parapatellar incision and tourniquet. Showing image position and incision. This is passing entry with the hole and passing a reamer using manipulative devices. This is a nail passed and most distal screw done. This is showing case 1 with fracture supracondylar in the post-op x-rays. The clinical photograph showing good range of movements. This is second case showing fracture pre and post reduction and good range of movements with clinical photograph. This is third case showing pre and post x-rays and showing good range of movement, no shortening or no any difficulty in knee range. This is fourth case, 45 in the male, showing pre and post x-rays and with nailing, good reduction achieved. And we achieved very good range of movements in all patients. Various options available. Operative blade plate, dynamic condylar screws, external fixator, distal femoral locking plate, supracondylar nail, cancel screw, and conservative for moribund cases. Mean operation time was around 53 minutes, mean blood loss around 100 ml. Mean hospital stay 5 to 15 days. Knee bending started on the second post-op day in the most of the cases. Partial weight bearing after 3 weeks and full weight bearing after 6 weeks in the simple fracture and complex fracture after 12 weeks by confirming radiological and clinical sign of union. Results. Results were assessed both clinically and radiologically for the 6 months to 2 years. Mostly results were satisfactory in the form of patient compliance and functional outcome. In the most of the patient, we achieved painless range of movements without any limb. Post-operative complication in the form of knee stiffness, malunion, patellar impingement and delayed union and pain at distal screw side were assessed. Supracondylar nail osteosynthesis is the method of choice for the surgical treatment of distal femoral fracture due to